Okay, guys. Time got ahead of me this morning. Sorry we're starting a couple minutes late. In case anybody's wondering, yes, I am going for my own Nancy Pelosi look. I think it's working out pretty well for me. I have two announcements. The first one is today is the Memorial Day for the astronauts in the space program who've been lost over the years. Some of you guys, many of you guys out there, weren't even born when the space program started, so you don't remember that any time that a rocket or a shuttle went up, it used to be a really big deal. Everything would stop. All the TVs were on. The day that the Challenger exploded in space, I was rounding, and they had a TV on in the nurses' station, and the resident I was with, I remember this distinctly, stood there watching it, and we watched that shuttle explode, and unbelievingly listened to the announcer, who took about 20 or 30 seconds to realize that something absolutely horrible had happened. Absolutely something terrible had happened. However, so today is the day that we're remembering these really brave people who literally went where no man had gone before. Now, the second announcement I have is much more lighthearted. You remember that last month I announced that for people who had the highest attendance at Grand Rounds, they were going to get a Panera gift card. Well, I am making good on my promise, and here are the winners, for this last month. Andrew DeFilippis, Sohail Ikram, Craig McLean, Omar Endeshaw, Forrest Arnold, Thomas Dews, Bridget Hittapole, Kimberly Leak, Stacy Mandrola, Tyler Sharp, Götz Klecker, Ujan Garg, and myself. I'm not quite. So with that, I'm excited. Yeah, and Steve McClave has them down there. I've got them down here. Anybody who wants their gift card, please come get it. If for people who aren't here today, maybe over at the VA or whatever, Jason Puckett will have them upstairs. With that, I'm going to ask Chris Kruger to come up and announce our speaker for today.
So I've had the pleasure in the past of introducing Dr. McClave. We all know him and love him because he's so engaging around the halls. He's always extremely friendly. He's actually taught at this institution for 34 years. He's the linchpin for our nutrition services. We take much for granted. Remember, in medical school today, it's less than a third of medical schools that have any nutrition curriculum whatsoever. Steve himself taught most of the curriculum for the longest time, and now their curriculum expands and is also sort of pushed out a lot of nutrition training. Residents realize this when they rotate, that they just expect the dietitians and the RDs to take care of the nutritional needs of their patients. Keep in mind, we have that as a luxury here, largely because of Dr. McClave and his colleagues that meet every Wednesday morning and make sure all your patients get the right kind of food. So the other thing you may not know, he has an extra fellowship. It's called the Nestle Nutrition Fellowship, and that is a very high level, highly sought after. You have to apply and be vetted and send in your CV. He's been doing it for 10 years. It's sponsored by Nestle, but what it is two institutions in Portland and here that will do two-week training sessions that are very intense training. A lot of the GI doctors and surgeons and trauma surgeons and a lot of high-level physicians from multiple institutions apply for this fellowship. So anybody here that wants to learn more about nutrition, particularly in the critical care, might want to apply for that fellowship. And with that, for the best interest of time, I won't go through all of Steve's contributions to nutrition, but just to let you get a taste of what he's going to bring to you today regarding how to feed a hospitalized patient. Thank you, sir.
Good morning. I jump at the chance to talk about clinical nutrition with my colleagues. This has been a career-long interest of mine, and hopefully I'll spark maybe a little bit of excitement in this topic for you as you go back and work with your patients in the hospital. These are my disclosures. And what I want to cover in the next 45 minutes or so are three things. I quickly want to touch base on this obsession we have with quality of evidence in the literature, because it's particularly damaging to nutrition. And if you're not careful, you can misinterpret the high quality studies, and that could be damaging for your patients that are expecting good nutritional care. The bulk of my talk is going to focus on the issue that strategies of nutritional therapy that support gut defenses and intestinal microbiome are more likely to change clinical outcome than strategies which ignore the gut and the microbiome. And then finally, talk about how nutritional therapy changes what we do in the immediate, acute, and post-acute period, and how that changes as we get into the recovery period of illness. Things change, and you need to be aware of how you need to ramp up and progress through a series of nutritional therapies. Now, I thought it'd be fun to maybe start with a pretest, just give me an idea of what I'm dealing with. You guys are supposed to be a pretty bright audience. So here's a Krebs cycle, and I'll just ask a couple questions to see if you would make a good nutritionist. All right, which enzyme converts citrate to isocitrate? Please don't look on your neighbor's desk. Well, this is the well-known aconitase enzyme. I didn't see a lot of hands. Let's go to question number 2. The enzyme phosphoenol pyruvate carboxykinase, nicknamed belovedly PepsiK, is involved in what process? Actually, somebody mentioned it, gluconeogenesis. This is the capability where you take products of amino acid metabolism and make glucose. Well, what does this mean if you scored well on this test? Well, assuming you don't have a biochemistry, PhD in biochemistry, chances are it means you don't have a lot going on in your life. And if we just took your name off the Christmas list for next year's Christmas party, the guest list. Well, let's just jump to the final exam, see if you do any better. Would you make a good nutritionist? Could you memorize 2 numbers, one for the protein goal, one for the energy goal? Would you recognize ileus if you saw it on a KUB or a physical exam? Could you work up diarrhea in a patient on tube feeding? Could you assess tolerance to oral diet in a patient with pancreatitis? Do these questions kind of sound more like in your wheelhouse, in our wheelhouse? This is what being a good clinician is all about. And being a good nutritionist is just a step beyond that. You just make sure that you think about nutrition, you address the problem, and you monitor the patient as you go through nutrition therapy. And that will make you a darn good nutritionist. And that's what I hope to share with you, give you some tools throughout the rest of this talk. That doesn't mean that there's not chaos in clinical nutrition right now. The last 5 years have been the hardest. We have these large randomized trials that show that a little bit of feeding is just as good as a lot of feeding. That enteral tube feeding or parenteral TPN, no difference in outcome. Some poorly designed studies suggest that the more we give them, the worse they do. And then you got quotes like this by 2 of the biggest researchers in the world in clinical nutrition, Michael Kassir and Greet Vandenberg, published in the New England Journal, in which they give this quote: large randomized recent trials have not generated evidence that providing nutrition early in critical illness results in clinical benefits. Basically, nutrition therapy doesn't do anything according to them. So this is tremendously misleading to clinicians. And if you kind of thought nutrition was a soft science in the past, you got more reinforcement for that right now. So let me focus on this right now, because there's a lot of fake news out there, as we all know, for the current administration. This is a guy I recognize that I kind of worship, or he's one of my gurus, John Ioannidis. This guy has an adjunct professorship at 4 different universities in America and in Greece. And 10 years ago, he wrote this paper, Why Most Published Research Findings Are False. And basically what he says is that the truth of a research finding is related to its reproducibility by subsequent studies. In other words, its positive predictive value. Sure enough, according to Ioannidis, large, well-designed randomized trials have the highest positive predictive value. And meta-analyses that are done well, that select and aggregate the data from sound, smaller RCTs, should have pretty close to the same positive predictive value. Nonetheless, Ioannidis shows that 10% of these large randomized trials will be discounted by subsequent trials. And in a paper by Laurier, a third of large meta-analyses will be reversed by a subsequent well-designed large randomized trial. When you dip down to observational trials, the wheels just absolutely fall off the bus because now you have the potential for confounding factors. And up to 85% of observational studies will be reversed by subsequent studies. What does this mean? It means as clinicians that we gather evidence from all the scientific information that is presented to us, that no one study is so good and so infallible and such a high positive predictive value that we pay attention to it at the exclusion of all others. That basically we will incorporate a study into our clinical practice, if the methodology is sound, the results are plausible, and it's supported by good physiology. One other aspect, when you see these large trials where a little bit of feeding is just as good as a lot of feeding, you have to keep this figure in mind. This is the mortality rate by a group of researchers, the ARDSNet research group. These are pulmonary critical care guys. They've been doing research for 30 years. 30 years ago, the mortality in the ICU was over 70%. Now it's less than 20%. So this is the event rates, in this case mortality. But you can imagine organ failure, infection, all those, the incidence of all those factors are decreasing, which means it gets harder and harder to tease out the benefit of any particular therapy. This group gave us low tidal volume minute ventilation, conservative fluid management. Advances in nutritional therapy paralleled this improvement in overall critical care. But it also means that if you set out to do a study and you do a power analysis here, and then you gather data and publish it 5 years later, the power analysis that said you needed 1,000 patients, now by the time you get through the study, you really needed twice that number of patients to show a difference. So the worst thing you can do is look at a study where a little bit is equal to a whole lot and say, oh, that must mean that nutrition just doesn't count. Don't make that mistake. So where can we point to a value of nutritional therapy? And I think it's in early enteral feeding. And this are not just my thoughts. This is the basis for the American guidelines, the Canadian guidelines, and then 3 months ago, the European guidelines, saying that nutritional therapy is based on the delivery of early enteral feeding. So when we did those guidelines 2 years ago, we asked the question, does delivery of early enteral feeding, and timing here is the number one most important factor, does early enteral feeding compared to not providing early enteral feeding change outcome? Now, these studies mean when they don't provide early enteral feeding, they either never provide it and the patient's got to kind of limp along and get back to an oral diet on his own, or they intentionally hold the feeding for 4 or 5 days. If you get early enteral feeding going, and this is absolute risk reduction, you can expect infection to drop from 51 down to 36% and mortality to drop from 14 to 8.7%. Now, these are criticized because the studies range from 1998 to 2014, and they're smaller randomized trials. But no data to date has contradicted this foundation for what we do in nutritional therapy. Now, another guru of mine is John Alberti in Chicago, a surgeon in Chicago. And he says that because the gut is such a large immune organ, it can really influence how a patient either recovers or deteriorates when they come into an ICU setting. He says it's not the diagnosis. You can have 10 people in front of you in an ICU with the diagnosis of pneumonia, but you're not sure who is sick and who is not as sick just on the diagnosis alone. But it's really where they are in this spectrum. In other words, if they come in, maybe they're not that sick, we get nutritional therapy going early, we support the commensal good bacteria to a symbiotic relationship, the bacteria benefit the host, there is appropriate immune responses, gut defenses are intact, and we can actually prevent organ failure and sepsis and move in this direction toward recovery. And we support the growth of the commensal organism. On the other hand, if the different pneumonia patient comes in, maybe they're a little sicker, or for various reasons we don't get nutritional therapy going, we start to slide in this direction, in which there's breakdown of defenses. There is dysbiosis, in which we get this virulent pathobiome that now has an adversarial relationship with the host. We get a inflammatory response, gut sepsis, and now the gut and this process begin to contribute to morbidity and even mortality. So the question is, with our nutritional therapy, can we shift patients on this spectrum? And the answer is yes, but we may not be doing enough with enteral feeding alone. Now, I want you to take just 5 slides on some of the more basic science on what is going on at the level of the gut. Yeah, as a gastroenterologist, it shouldn't shock you it just amazes me. But in a normal, healthy day, we're all sitting here in hopefully a healthy situation. There's this ongoing signaling between the bacteria in our gut and the host, specifically the epithelium. This is called crosstalk signaling, and it occurs because of binding between the commensal organisms and toll-like and nod-like receptors on the surface of the gut epithelium. These are the pieces of the commensal bacteria. The commensal bacteria don't have the machinery to stick or adhere to the intestinal wall. So it's just the little pieces. They're flagella, the pieces of their cell wall, the endotoxin. And those pieces bind to these toll-like and nod-like receptors. And depending on which cell type it binds to, it supports every aspect of gut defenses, which means if it binds to an epithelial cell, you'll get tight junction proteins expressed and the junctions tighten up. If it's a goblet cell, you'll get more mucus production. If it's a Paneth cell, it'll dump more defensins into the lumen of the gut and bind pathogens. And then there's this odd-looking dendritic cell. It can actually affect immune responses. So this is a close-up of this cell right here with all its arms and legs. It binds to a piece of the commensal organism and then in turn binds to a naive lymphocyte. And then it's going to educate that lymphocyte and lead to a proliferation of cell lines. In critical illness, all this changes. There are functional changes. There's increased permeability because the tight junction proteins have dropped. There are big physical defects because of increased apoptosis, and the microbes can now penetrate through the wall. The repair mechanisms that fix this are compromised. The mucus layer is thin. That's going to cause trouble for us in a minute. And there's this generation of this toxic gut-derived lymph that passes out in the lymphatic channels and then is going to go out the distant organs and cause failure. And the bugs that were a minute ago were commensal and friendly. Now, within 6 hours, 90% are gone, and you have the emergence of these virulent pathogens. The immune dysregulation is fascinating. In health and homeostasis, the MAMPs, the microbial associated molecular patterns, the pieces of the commensal organisms, stimulate those dendritic cells to cause the naive lymphocytes to go in this direction toward the production of Th2 lymphocytes. This is involved in humoral immunity. In critical illness, now the pathogens emerge, and we have pathogen-associated molecular pattern. This is the actual pathogen organism that binds to the wall of the epithelium, and danger-associated molecular pattern, DAMPs. These are pieces of necrotic cells and DNA from their mitochondria. These pieces of cells and the actual pathogens, now their binding sends this signaling in an opposite direction. And the naive lymphocytes become Th1 and Th17 cells. This is a different picture showing the same process. In health and homeostasis, this is the line of proliferation of lymphocytes we see, and the patient moves toward recovery. In critical illness, a different population emerges that is pro-inflammatory, and that's why we see SIRS or gut sepsis. This is what causes gut sepsis. And the other term for this is immune dysregulation. And then this fascinating progression from microbiome to pathobiome. These pathogens are already there. They sense the host is going down. They say, we're better off if we kill this carcass, kill the host and live off the carcass. So they become virulent. And look at this picture. This is a Pseudomonas that's still in the commensal phase. Here it has gone phenotypic change, and it grows little arms and legs, and this is the virulent phenotype. And guess what? It can go into it and back out. So if we make it angry, it'll go like we give an opioid, that stimulates virulence. We give it some phosphate, it'll come back out. It doesn't like to stay in the virulent pathogen. It's a kind of a road of last hope. So they go in and out of it. If they go into virulence, they can adhere to the epithelium. They destroy the commensal, so 90% are gone quickly. A biofilm develops, and it can attack the epithelium and destroy it further. What happens is you get loss of biodiversity. That by itself is bad. And what emerges is one growth of one organism, the pathogen. You get septic morbidity, you get this toxic lymph forming, it leads to organ failure and antibiotic resistance. This gut-derived lymph that I keep talking about, we've known for years in a lab animal that if we don't feed them, that can contribute to organ failure, like respiratory failure. And if we ligate the thoracic duct, we can protect against that. Well, what's going on? Well, at first we thought it was bacterial translocation or their products, their endotoxin or cytokines getting into the portal vein. Then we said, no, it's not the portal vein. Is it the lymphatics? Well, we know it's the lymphatics, but we can't grow any bacteria out of the lymphatics. Finally, through a long evolution of studies, it turns out that the pancreas is the culprit. And the connection here is that with the breakdown of these defenses, that mucus layer gets thinner and thinner and thinner. And that allows the pancreatic enzymes to pass into the epithelium, and it destroys the epithelium. You know, pancreatitis is a situation where the enzymes get activated and destroy the gland. Well, here the enzymes get into the epithelium, destroy it. That allows the pancreatic enzymes to get past the epithelium into the lymphatics. There you've got lipoprotein lipase, protease. This acts on the fat that you're absorbing through the lymphatics to produce fatty acids. This is what causes the toxicity. And the significance of this is you follow the roadmap. The lymphatics go into the thoracic duct, dumps into the left subclavian vein, out through the heart to the capillary pulmonary bed. The first capillary bed it gets to is in the lungs. And that's why respiratory failure is always the first organ that goes in organ failure. But it'll go on to get the heart and the kidneys and everything else. One last slide before I want to come back to the more clinical aspects of nutritional therapy. And this is a part that's fascinating to me. And it may be fascinating because I just didn't know anything about it. But it's looking like critical illness is a classic model of mitochondrial failure. And this is interesting for a number of different reasons. First of all, as the mitochondria fail, they start leaking and they dump their DNA into the circulation. And that DNA acts like it is a DAMP, a danger associated molecular pattern. The other name for it is alarmin. Same thing. This is a graph looking at survival in critically ill patients. And if the danger associated molecular pattern, this DNA levels are low, survival is a lot better over time. But if those levels are high, survival's a lot worse. And so this spilling, this mitochondrial failure and the DNA spilling in the circulation becomes a marker of disease severity, and it's linked to end organ failure and inflammatory responses. Remember that the mitochondria is kind of the battery of the cell. So if you're looking at muscle in a post-ICU weakness, if you're looking at organ function in a patient who's critically ill, to have the battery go bad on you is going to lead to organ failure and muscle weakness. And this is the other point. This just one last slide, and I'm going to come back to the practical stuff, is what does this mitochondrial dysfunction mean when we go to feed a patient? And we don't know yet, and we haven't incorporated into anything that I'm going to talk about the rest of the talk. But I just want to show you this because it's crazy. This is an elite athlete, a diabetic patient, and an ICU patient. And on this graph, we're exercising them. In this case, an exercise bicycle. If you look at the muscle of an elite athlete, he's got tons of mitochondria in his muscle. And you put him on a bike and you push him to near death, and he can maintain fat metabolism to a very high level. But at some point, you push him past his point of tolerance, and the fat metabolism falls off, and he's totally dependent on carbohydrate metabolism. Now, the significance here is that fat oxidation only occurs in the mitochondria. Take the diabetic patient, not an athlete. Here, just a little bit of the exercise bike, and his fat metabolism falls off like a stone, and he's totally dependent on carbohydrate metabolism. But now look at the ICU patient. And when we've looked at electron micrographs of the muscle of ICU patients, they have like a tenth of the mitochondria that an elite athlete has, and they look real ratty and chewed up. Now, there is absolutely no fat metabolism because of this mitochondrial failure. The ICU patient is totally dependent on carbohydrate metabolism. 2 months later, after he's been discharged from the ICU, I don't know if you can see this well, he is still right down here, absolutely no fat metabolism. And finally, 6 months later, he begins to have fat oxidation return. Now, we don't know what this means yet, but keep in mind, we're pounding them with calories and expecting them to do well. So we really don't understand what's really going on at the most acute phase of illness. So let's come back to the clinical stuff. You're at the bedside, you got a sick patient in front of you. Should you look around and define malnutrition? And the answer is no. I've been on 10 committees trying to define malnutrition 35 years. We still can't define it. So what we've replaced it with is nutritional risk. And this brings out two aspects that are very important. One is nutritional status, but the other is disease severity. Both of these things will drive nutritional risk. The best thing that scores that degree of risk is the NRS 2002, Nutritional Risk Score 2002. The concept is great, the tool is mediocre. When you look at this table, you start on the left side, and you get 1, 2, or 3 points based on weight loss, decreased PO intake, or low BMI. Then you go to the other side of the diagram, and you get 1, 2, or 3 points based on increasing disease severity, and they give you examples. And that's where it falls apart. The examples aren't great. You look up pancreatitis, it's not even on the list. But the concept is very important. Both disease severity and nutritional status drive risk, as does age. You get an extra point for age. And so high risk would be a patient with 5 points or more. Now, the problem is, what do you do with this? What does it mean to you as a clinician? Well, the first thing is it has prognostic information. It tells you who's sicker, who you're going to have more difficulty feeding, and who's going to have more trouble with tolerance. A big thing in nutrition right now, we have 5 or 6 different grading systems for GI intolerance. This is one that shows the association, not cause and effect, between increasing GI dysfunction and survival. So if you have active bowel sounds and no abdominal distension, you're grade 1, your survival is the best. By the time you have distended abdomen, ileus, evidence of ischemia, your survival is much worse. And then finally, this nutritional risk tells you the urgency with which to get feeding going. You may have to ramp up faster in somebody who's high risk. If you can't do tube feeding, you may go to TPN sooner if the risk is high. Now, the next thing is to calculate your energy and protein goals. And we're going to have a discussion here all over the map in a second, but I want to give you 2 numbers. And believe me, if you can memorize these 2 numbers, you will be a nutritional genius the rest of your career. And that's 20 calories per kilogram per day and 2 grams of protein per kilogram per day. Now, some people are going to come in above that and below that, and I'll show you that controversy. But this is your reference point. And literally, if you failed everybody the rest of your career, you'd be great. Does the goal have to be exact? And the good news is, no, it doesn't. And that was proven by this study. I get a kick out of this, the EAT ICU trial. They randomized patients to very specific goal-directed nutritional therapy. They used the metabolic chart for calories and the urine, urea, nitrogen for nitrogen balance to direct protein. The other group, they just used 2 numbers like I just gave you. At the end of the trial, the tight goal group did no different than the loosey-goosey. You got a rough number and get as close as you can. There's no difference in outcome. So that's a nice thing. That tells you you don't have to use the Mifflin-St. George equation or the Harris-Benedict or anything else like that. Just use a simple weight-based equation. You may need the cart if there's edema, obesity, amputation, because then the weight-based equations kind of get screwed up. You never need urine, urea, nitrogen. You can forget that. Right now, a big thing in clinical nutrition is we're pushing protein. And if you wonder what this picture is down here, I Googled jumping on a bandwagon. I don't know if we're on the right track of this, but this is clearly a big part of nutrition right now. And it's based on this kind of information. This was an observational trial from Europe in which they're looking at survival. This is a little bit of protein. This is more protein. This is the most protein. That the more protein they got, survival was much better. This is another thing that's really disturbing kind of, but if you look at mortality with respect to energy and providing calories, it's U-shaped, which means as you give more calories from 0 to about 70 to 80%, the best survival is about 70 to 80% of requirements. And then look, the mortality starts going back up beyond that. So too many calories may not be a good thing. But protein, on the other hand, keeps going down and you get to 100% of requirements and it might actually keep improving. And there's some belief that we know there's anabolic resistance. Anabolic resistance means we give you the protein that we might give a young, healthy person, but you don't get it out of the splanchnic circulation. You might not get it out of the blood into the muscle. You might not stimulate the mTOR protein synthesis as great. You have anabolic resistance. Old age, critical illness, laying in bed for a week, all those things contribute to anabolic resistance. And we think that if we push the protein hard, we can overcome that, but we don't know that for sure. Right now, we're kind of in a period of where we're bashing calories. And if you think, what am I talking about? Well, nutritionists can be hard on ourselves. The whole world's hard on nutritionists. The nutritionists are hard on each other. For years, the phenomenal work of Ansel Keys has been bashed, that he misled us with his cholesterol stuff, and he really did us a disservice saying all fat was bad. Then you got idiots like Mehmet Oz saying that carb bashing, and that if we just avoided carbs in our diet, the world would be a better place. Well, now we're bashing calories. And this is a perfect example. This is a trial that just got published 3 months ago. But it shows that it was designed to say, should we push the calories to goal? And the answer is maybe no. This is from Australia, and they did it by randomizing patients to 1 calorie per cc formula or 1.5 calories per cc formulas. So the patients got the same volume of formula. It was double blind. They didn't know there's more calories, 50% more calories in one than the other. Protein was the same. And at the end of the trial, look at that. 90-day mortality, no difference. Every other outcome, no difference. So the answer, if you got the protein the same, pushing the calories and getting it to goal or above doesn't change outcome. And if you overfeed them, you could actually make outcome worse. So what's more important, the protein or the energy goal? Well, obviously, I'm alluding to the fact that it's the protein goal we think is more important. And a small group from the country of Colombia illustrated that with 2 subsequent studies. In one trial, they held the protein the same between the 2 groups and just gave more calories to one than the other, no difference in outcome. In the other trial, there was a big difference in the protein, and actually the high protein group got fewer calories, but they did better. Their SOFA score, a measure of organ failure, improved faster. This is a second trial with TPN. Patients were given what they were supposed to get, 25 calories per kilogram per day, and then they randomized a group to below that, 20 calories per gram per day, and 80% of the protein. And look at this, they did better. Infection and organ failure was better if they backed off of the calories. So basically we think now that high protein, low calorie may be the best option. And what we're starting to do is start with our regular formulas, which don't have enough protein, and adding protein supplements early on to get the protein up while we kind of go more slowly in the calories. Now, big questions. Where does trophic feeding or permissive underfeeding fit in all of this discussion? Well, these are 2 trials. You've probably heard these terms in the literature, but here's one, the Eat and Omega study from the ARSNet group, randomized patients to just 20 cc's of formula a day versus goal feeds. At the end of the trial, the goal didn't quite get there. They were at 80%, and the 20 cc's per hour turned out to be about 25% of goal feeding. And then after 6 days, they ramped up. No difference in outcome between the 2 groups. That's trophic feeding. 20 milliliters is 2 tablespoons an hour. Then a group from Saudi Arabia did the permit trial. They randomized patients to about 50% of goal feedings versus full feedings, protein the same in both groups. Again, at the end of the trial, the permissive underfeeding group did just as well. Every outcome parameter was the same. So how do we rationalize this in our mind? How does a little bit of feeding, particularly trophic feeding, seem to have the best, just as good an outcome as full feeding? Well, one of the answers is this very short therapy, about 5 or 6 days in this trial, a little longer in this trial. But here's one of the reasons, that there are non-nutritional benefits of what we do and nutritional benefits. And this trophic feeding, this 2 tablespoons an hour early on, may be enough to cover our bases. And it's all these things related to gut defenses and supporting the microbiome. That's different from the nutritional benefits. That we may need. Nutritional benefits come from full dose feeding. And it may be because the patient's an alcoholic and they got micronutrient deficiencies, or they have sarcopenia before they ever got sick and came into the hospital. And these patients don't do well with less feeding. They need more feeding. They need goal protein and goal calories. So trophic feeding may work because it covers our basis for the non-nutritional benefits. And here's a second reason that trophic feeding might work is now, 5 years ago, if I were giving this talk, I would have said, push, push, push. Start enteral feeding, get the goal in 24 hours, and be very aggressive. Now we're saying that's not the right answer. It's a slower ramp up. Maybe take 3 to 5 days to get the goal and get to your protein goal first and get maybe to 80% of your calorie goal, and then in recovery going up to 100%. And these are the 5 reasons. First of all, there was an elegant randomized trial of early enteral feeding versus TPN in very sick ICU patients. And they started feeding within 24 hours and went to goal the next 24 hours. And 19 patients had bowel infarction that required surgery. And only 5 patients in the TPN group had bowel infarction. So pushing too early, too hard in a patient on pressor agents who's septic can bring out infarcted bowel. So you can't, that's a reason to go slowly. A second reason is shown down here. When you're critically ill, your liver pours out glucose. There's this gluconeogenesis, and we cannot suppress that. Anything we provide with our feeding is added to that glucose pouring out of the liver. And if you add those things together, you can inadvertently overfeed somebody early on. And overfeeding is a stress. You don't want to do that. So that's a reason to go slowly. Also, refeeding syndrome. This is unbelievable, but this is a randomized trial from Australia in which ICU patients, they started feeding, and if the phosphate dropped out of the normal range, then they randomized them to a rapid ramp up or a slow ramp up. If they pushed the calories up rapidly, the survival dropped like a stone, and they were killing patients with aggressive feeding. If they went slowly and took 4 or 5 days to get the goal, the survival was much better. So if that phosphate drops out on you, you've got to back off, because if you provide feeding, you'll actually hurt the patient. Also, there's a concept of autophagy. Feeding suppresses autophagy. We need autophagy to clean up muscle to reduce post-ICU weakness. So theoretically, if we feed less in the first few days, we support that process. And then the other thing as a clinician, you're watching tolerance, and you don't want to be aggressive. You want to give them a little feeding and see if they push back. We think that the basis of nutritional therapy in a hospitalized patient is gastric feeding. It doesn't need to be in the small bowel early on. You start with gastric feeding, and that's your basis for your institutional practices. But it doesn't always make sense, and it can be counterintuitive at times. We know that GI dysfunction is common. Probably up to 85% of patients have evidence of delayed gastric emptying, and yet gastric feeds are probably successful in 95% of patients. You don't require bowel sounds to initiate therapy. A decompressive NG tube, because you got an ileus, actually makes things worse, not better. And there's a big movement now in post-operative care to get rid of nasogastric tubes. And if you do switch from gastric to small bowel feeding, the only thing changes is pneumonia. But length of time in the ICU, how long you're on the ventilator, none of that changes. Only that whether or not you got an infiltrate on chest x-ray. The definitions of GI intolerance are vague and elusive, but the more evidence of intolerance you have, it's associated with increasing complications and increased mortality. Our monitors are not good, and are now encouraging you to stop using gastric residual volumes and just look at the patient and examine them. And I'll show you why in the next slide. So understanding why this all works is tough, but gastric feeding is the basis of how we deliver care in the hospital. These are the 2 studies that just nailed residual volumes. And residual volumes seem intuitively obvious to us. If we're pouring feeding into the stomach and we're getting large volumes back out, then we need to stop. But they are just an absolute worthless measure. And these 2 trials drove it home. This was a Spanish trial, randomized trials, where they just raised the number ridiculously from 200 to 500. No difference in outcome. And what you did when you raised the number was just give more feeding. But you didn't get more pneumonia, no more vomiting, no more aspiration. And then a French multi-center trial said, look, let's just stop doing residual volume and see what happens. And again, no difference in ventilator-associated pneumonia, infection, or mortality. And what it meant was you fed more and cut the deficit more. So this is why we're telling you, just don't order residual volumes. And it's hard to do. And the nurses will drive you nuts because they are born in their DNA with with residual volumes. When do you go from gastric to small bowel feeding? When do you pull the trigger? And the answer is it's a soft call, because literally the only difference is pneumonia. And I keep saying that, but at one point I turned to one of my critical care guys and I say, well, does that mean an infiltrate on chest X-ray doesn't mean much? And he goes, well, we're trying to figure that out. Because if the duration of mechanical ventilation doesn't change, ICU length stay, nothing else changed, does it matter whether there's an infiltrate or not? I'm sure the pulmonary guys are going to kill me after this. But the problem is when you go from gastric to small bowel feeding, it involves expertise, meaning you got to have somebody in IR or GI or surgery that can get the tube into the small bowel or past the pylorus, or our dietitians can get it past the pylorus. You have to have availability. It leads to delays, and there's some cost associated with it. The usual reasons that we're switching to small bowel feeding is because of high residual volumes, which, as I've already said, are shaky, or just the fact that we keep stopping it for tests or procedures. We can't advance because of perceived intolerance, or we think we have to have the tube in the small bowel because of pancreatitis. So this is a soft call. Assume that you're going to feed into the stomach and try your hardest, and only if they're clearly intolerant or there's such high risk of aspiration that you really are nervous, then get the tube in the small bowel. What's the optimal formula? This has gotten easier over time. As a doc, you just need to know concepts. And in a medical ICU, a standard Ford Chevrolet, that's called a polymeric formula, is the right choice, because no other formula seems to change outcome. In the surgical setting, though, a surgical ICU or elective surgery, arginine fish oil formulas, the immunonutrition of the past, that still has been shown to reduce infection and hospital length of stay. We never bought into the fish oil only formulas that were anti-inflammatory, supposed to reduce risk in ARDS patients. Nobody really, the data there is too shaky. And we don't really push small peptide MCT formulas or organ failure formulas. Resist that urge when you have liver failure to order a liver formula, or if you have pulmonary failure, order a pulmonary formula. They even got the lungs on the can to help you. Avoid that. You don't need that. They don't change outcome. Now, if we come back to this spectrum, we have to ask the question, does just starting enteral feeding do the job and actually shift patients on this spectrum? And the answer is it's a good start, but it's not enough. We know that enteral feeding is associated with less inflammation in the gut than TPN, that gut sepsis is more likely in a patient on parenteral nutrition. The problem is the formulas we use are absorbed very high in the GI tract. So TPN certainly doesn't get down to the cecum where the biggest microbial burden is, but our tube feeding is absorbed up so high that it doesn't get down to the cecum. So if the name of the game is not just gut defenses, but supporting the commensal bacteria, we got to get down to where the action is. So there's some strategies that we're starting to adopt. And as a gastroenterologist, it's easy for me to say judicious use of antibiotics. That just means if the cultures are negative, stop them. Have shorter courses of the antibiotics. Don't do it prophylactically unless there's very good evidence to support that. And opioid narcotics. We've bought into this, no patient in our hospital should feel pain. Well, guess what? Opioid narcotics stimulate virulence. It'll push these potential pathogens into their virulence phase. So avoiding those or using other agents to accomplish the same effect, like sedatives, might be the answer here. We should be moving quickly to soluble fiber. We have soluble fiber additives. Mixed fiber formulas are very important. Europe says that an ICU patient should get as much fiber as you and me walking around on the streets. And blenderized whole food formulas. These will get further down in the GI tract and get closer to where we need them down in the, and there are commercial products for that. Soluble fiber is absolutely magic. And we now in our recommendations say every patient in the ICU should get these because they produce short chain fatty acids, and butyrate is the magic bullet here. And butyrate can do every one of those things that I started with. You know, when I talked about commensal signaling and every aspect of that commensal signaling builds up gut defenses, that's what butyrate does. And that's as simple as giving 30 cc's of a fiber supplement a couple of times a day to an ICU patient. What about probiotics? You know, this is what happens with antibiotics. It is a contributor to decreasing the commensal population and allowing the virulent pathobiome to grow. And what we're really interested in is refaunating the whole commensal garden. And probiotics is a step in the right direction, but may not be the full answer. What has kept us from being more aggressive with probiotics is this Dutch Propatria study in pancreatitis. And if you remember this study, these guys fed probiotics to severely ill pancreatic patients. The controls got fiber formula, as did both groups, but did not get the bacteria. And at the end of the trial, organ failure was twice as much in the probiotic group, more surgery, more ischemia, and higher mortality. And this just scared the daylights out of everybody, that we shouldn't touch patients that are critically ill with probiotics. But guess what? This stands alone. This is a meta-analysis later on, 5 other studies in pancreatitis, and this Dutch group is an outlier. And it's because they were so aggressive. They had the tube in the small bowel, they had mixed fiber formula, prebiotic fiber, 6 organisms, twice a day, 4 weeks instead of 1 week, and they fed on 3 pressor agents directly into the small bowel. They're just too aggressive. Every other randomized trial of probiotics in any critical care setting, we don't even have a case of bacteremia associated with a randomized trial. This is something we should do better. And I have a buddy out in Portland, Bob Martindale, who takes Nancy's kefir, this kind of liquid probiotic, and swabs the oropharynx and puts it down through the feeding tube. We have got to get better. This is a no-brainer, and it's safe. There's some novel approaches that we may be moving. If we really want to shift somebody on that spectrum, here are some things we may need to do. Bacteria love phosphate. And if we can just get the phosphate to these bacteria, they will come out of the virulent phase and go back into a commensal lifestyle. The problem is if I give you phosphate in this room, you'll absorb it very high in the stomach or proximal duodenum. But John Alberti in Chicago has figured out that if he sticks phosphate onto polyethylene glycol, which is the stuff we use and go lightly to clean you out for a colonoscopy, that will carry the phosphate down to the cecum. The bacteria cleave it off, utilize it, makes them happy. They'll stay in a commensal lifestyle. There's a commercial product that's made from cow's immunoglobulin, literally in the what's it called, the butcher shop, where they kill the animal. They drain their blood into a bucket, and they take the blood from 300 cows per mixture, and what they're extracting is IgG. Now, IgG is a better, more mature immunoglobulin than what we make, IgA. And these cows stand in these feedlots and poop right there where they're standing, so they have antibodies to every bug that counts, C. diff and staph and Pseudomonas, all those things. And this is a powder. We can mix it up, give it to a feeding tube. This might help bind these pathogens before they can have virulence. And then finally, there's a commercial product called Specialized Pro-Resolving Molecules that is the end product of EPA and DHA metabolism. These are resolvins, is one of their names. And these shut off inflammation, actively shut it off. And then finally, this is the craziest thing, but it's the thing that fascinates me the most. Should we be using fecal microbial transplantation, in an ICU or a hospitalized setting, in non-C. diff situations? Now, the deal here is, again, when you're critically ill, you're going to lose 90% of the commensals in 6 hours. Most of them are killed. The rest are sequestered into hiding places. One of the hiding places in the crypts of the intestinal epithelium. This is a micrograph showing these commensal bacteria stuffed in these little crypts. They also hide them in the tertiary bronchioles of the lungs. If the process goes on too long and we don't do efforts to repopulate the commensals, eventually the crypts vacate or are absent. And then what happens is the virulent pathogens will colonize the crypts. And the only thing that, one of the fastest and most reliable ways to reverse that is to give fecal transplantation. Now, this is a report card from John Alberti's group of an actual patient in the surgical ICU, and he lived for about 51 days. This is a report card of all the antibiotics he got through those 21 days. These are the times that a virulent pathogen showed up in the urine, the blood, or the peritoneal space. This is a 16S ribosomal sequencing showing that instead of 5 beautiful colors of phyla of bacteria, he was down to 1 phyla, and it was a pathogen. That's called loss of biodiversity. And then at the bottom, these colored boxes are the bugs and all the antibiotics they got. And every time you see a colored box, it's antibiotic resistance. So this process, if we don't turn it around, leads to antibiotic resistance, septic morbidity, emergence of this virulent pathobiome. So how can we turn this around quickly? Well, we've learned a lot as gastroenterologists with treating C. difficile pseudomembranous colitis. We've learned that if we put it in the cecum, that's the most reliable way. We go in with a colonoscope, deliver it to the cecum, we can eradicate it to a greater degree than if we just stick it in the rectum. We can go the southern route or we can go the northern route. In the northern route, we go down with an endoscope, get past the ligament of Treitz, squirt a smaller volume, and that is associated with a slightly reduced clearance rate. But if we just do it a second time, we can jack that right back up as if we had delivered it in the cecum in the first place. So we're learning the best way to deliver stool to the patient. We now have commercial products. In the old days, we had to go to a family from Kentucky and they come in from Hazard and patient's sick and we go, we need family members, we need stool from someone. All their hands go up. And they say, well, you can't have been in jail. A couple of hands go down. You had no recent tattoos, more hands go down. No illicit drugs, all hands go down. And you got to stop by Walmart and get a $60 blender that you're never going to use again in your life. All that is gone because we have a commercial product that costs just $200, half the cost of this big workup. And we can deliver that. We just take it out of the refrigerator and thaw it. But guess what? Now they have this lyophilized powder and a sterile filtrate. They can take that stool, run it through a filter, and we just take their product. Remember at the beginning that commensal signaling? All we need are their pieces. We don't need the live bacteria. So sure enough, you can take these products and they will have the same effect nearly as the intact stool. In fact, there are now 5 cases in the literature of patients in the ICU without C. diff. They did have diarrhea, and I think that's what gave the investigators the guts to try this. They gave them a fecal transplantation. The biggest thing that happened was the SIRS response, that toxicity. That reversed in 24 to 36 hours. Immediately, they shifted on that spectrum. It took a little while longer to get rid of the diarrhea, but this is the best example of this concept where we can shift them on this curve and move them in the right direction. Should we be using TPN? The answer is yes. There are 2 large trials, enteral versus parenteral therapy in England and again in France. Short-term enteral versus short-term TPN, no difference between the 2 groups. Does this mean they're equal? And the answer is no. We still prefer enteral over parenteral. It just means that if you can't get the job done with enteral feeding and they're high risk, you're going to need to go to TPN sooner. And these are the guideline recommendations. If you cannot do tube feeding and you're trying to decide whether you need to start TPN, if they're low risk, it's okay to hold it for a week or more. If they're high risk, you need to start it immediately. If you're already on tube feeding, that's getting the job done. You don't have to worry about adding TPN to that for probably 7 to 10 days. And when you do, you want to have a multidisciplinary team, good backup of your pharmacy, moderate glucose control. And this is my last slide. Most of us in this room probably live in this phase. If you're not an intensivist, our patients are out on the wards and we're delivering nutritional therapy here. But if you're intensivist, you're heavily involved in this acute and immediate post-acute phases. This is the first week of hospitalization. Everybody agrees that timing is the most important part. So they come into the ICU and getting something started by the enteral route is the most important aspect. But we're going to go slowly here. And during this first 3 days, we're going to assess their nutritional risk to see how fast we're going to have to push later on. Are they showing evidence of intolerance? Is fluid resuscitation nearly complete? And is there any evidence of refeeding? Is that phosphate squirreling around on us? Then at some point, we go into the immediate post-acute phase. Here we switch from nutritional support to nutritional therapy. Should be getting to our protein goal by now, 80% of our calorie goal. Now is when we would start shifting to whole food formulas, make sure we got fiber, probiotics. Exercise needs to start now, not later. And fecal transplantation would be a consideration if the ball's getting away from us. And if we couldn't do this enterally, we'd start TPN. At some point, the patient emerges and goes into the recovery phase. And here's where we need to be at goal for everything: exercise, supporting bowel function and microbiome, and getting the patient up and exercise. Thank you for coming today. It's a joy for me to get to talk about clinical nutrition, and hopefully got a couple times for questions. Thank you. Yeah. Yeah.
So in your mind,
I think the biggest change is now, the early change 10 to 15 years ago was the shift from heavy dependence on TPN to tube feeding. And the biggest change in the last 5 years now is this: don't be as aggressive. Start it early, but go more slowly, and watch for tolerance and low phosphate and things like that. And then the other change is, and at some point toward the end of that first week, middle of that first week, if they're really high risk, is using more TPN. I think our residents go around thinking they're going to get in trouble if they order TPN, and that, you've got to get that out of your head. TPN, we can do it safely now. The care of the central line is better. Glucose control is better. So you have new TPN as your backup, and that's the biggest thing that's changed. But I think we're right on the cusp of saying, look, nutritional therapy is not just about the calories and protein. It's all these other things: the fiber, the probiotics. It may be fecal transplantation. It may be binding the pathogens. It may be shifting the virulence profile, and all that may come into the wheelhouse of the nutritionist for providing nutritional therapy. Yeah. Wow. You mean actually testing the bacterial populations? Oh, that's neat. I haven't thought of that, but that would be a great measure to see. Butyrate is just magic. And if you did two types of therapy and you got higher butyrate levels, I think that would be good. But that's an interesting aspect to it. I thought you were going to say, should we be like testing the stool and trying to modulate the firmicutes to Bacteroides ratio? That's very, very complicated and very difficult. Yep. Yeah, that's a good point. Oh, tributrin. Yeah, I've been very excited about the bone marrow transplant team now that you guys are looking at these issues in nutrition and applying it to one of the sickest group of patients in the hospital. There is this tributrin, which provides butyrate, but I haven't had any experience with it, and I haven't seen it used in a setting of nutritional therapy. You guys haven't used it, have you? Yeah. 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 No. No. These are fabulous points, and I'm reminded by anybody that does rat models in nutrition that says nothing beats rat chow. So if we can get normal food into a patient, that beats anything I've talked about up here. The neatest thing I saw was at Sloan Kettering in New York. They had a picture of the chef, and it's like a restaurant and a hotel, and you have room service. And the patient, the meal comes at 4:30 in the afternoon. They may not feel like eating, but suddenly at 8 o'clock they feel like eating. They can call down to room service in the hospital, and they had a chef, looked like a French chef, mixing up these fancy meals. And of course that's sounds like it'd be very expensive. I don't know, but the idea is you meet their needs, not the needs of the schedule of the cooking staff. But, yeah. And another small piece of that is never order clear liquids. That we don't need clear liquids, even in a setting like pancreatitis where it makes physiologic sense. Go straight to a solid diet and as you advance diet. So great point. What'd you say has butyrate in? Butter. No, but and this is where dietetics, I'm going to really fall down pretty fast here. But what we eat can markedly affect the production of those 3 short-chain fatty acids. Now remember, that soft drinks and diet drinks can decrease the butyrate production and generate the production of the propionate and acetoacetate, and that's bad. That has a negative health effect. And so I don't know if we should be giving butter to our patients, but you got a good point that what we feed can drastically affect the production of butyrate, and I think we need to focus a little more on that. Yeah, that's a guess. Well, I'll just talk.
Okay, with that, I think that will call it quits.
Please. Thanks.